Hello, how are you?
Okay. Dr. Bob?
Okay, can you hear me?
Okay, I can hear you.
Okay, I'm here is Asan Medical Center. I'm DW Park. I think this time is a very, very valuable time to discuss our complex lemon PCI with the lemon pioneer H.J. Park and the crush technique, the pioneer Antonio Colombo, and the DK crush pioneer Xiaoling Chen, and the many imaging experts, the Kyung-Jung and Eki Gomera, and many experts in complex PCI field. So I'm gonna introduce our team. My first assistant is Cheol Lee. He's our previous fellow, now assistant professor in the Gaemyeong University of Dongsan Medical Center. And another, our senior fellow is Seung-Jung. And we are all together do the lemon PCI. Okay, Professor Lee, can you explain the patient background?
I'll introduce this case. He is a 50-year-old male man, and he complained of chest pain 1 year ago. He had a history of hypertension and hyperlipidemia. Coronary angiogram showed left main true bifurcation disease with acute circumflex angle. Next. Yeah. Echocardiogram is normal finding, and syntax score is 17 points. Next. Yeah. We will show coronary angiogram data part.
Okay. So, and this is the audio. Okay, and this is a distal lemon bifurcation, the 50 years old female with a stable angina. And the next slide, the syntax score, just 17 is a low syntax score. Looking at the area coral view, you can see the very severe stenosis, osteum, also the distal lemon disease. This is area coral view, and the suck region, proximal suck region is extended to the big OM branch. And next one. So this is the spiral view. You can see the distal lemon bifurcation. Also, there is a stenotic region in the area osteum, and the suck region was very tight. Looking at this interesting point is, angle is very acute. This is a very complex lemon PCI. And the next. Okay, this is the spiral view. Previous one.
Spider.
Okay. And this is the spiral view. You can see the how much narrow the distal lemon and how much angle the suck osteum. And then next. Okay, this is the epicranial view. LAD is okay, and the region was confined to the LAD osteum and the distal lemon. Usually, we select A-branch femoral approach guiding caster, and then this is a summary for this patient. For any comment or question from panel or audience?
Dr. Bang is here. Antonio is here, and so. And how to do operate is good. However, before that, right coronary artery is quite good. And for particular this bifurcation lemon disease, still or not still is. Want to bypass surgery for this patient, Antonio?
I would say yes.
Can
I see the spider or the caudal view again?
Caudal.
Okay.
Okay. So I think here I will really do all my best to go with one stent, because when you have this steep angle, relatively small circumflex, there is stenosis. If you place two stents, it's going to be prohibitive.
Okay. Previous one.
I would be inclined to accept not a perfect result, but to go with one stent.
I would like to see the IVUS before deciding what to do. I think it is very important to check with IVUS the distribution of plaque and the importance of, the size of circ. Circ seems to be important vessel and tight osteal lesion, but I think also it's some disease also on marginal as well. So I think it is good to see IVUS before.
Okay. Yes.
Anyway,
yes, your comment is good.
Do you want to do stent for surgery? Okay, no problem.
Okay, no problem. Yeah, angiographically, it looks intermediate stenosis at the ostium of RAD. Even there is mildly plaque at the ostium surface, angiographically, I don't think it's a good candidate for two-stent technique because of the relatively low syntax score. So it should be a good patient for PCI. But personally, I do think, or tell whether I was used or not, prominent stenting technique is a pretty good stenting technique. The reason is that very short lesion at the proximal surface.
IVUS first. Dr. Bach, would you show us IVUS?
So, okay, got it. And to sum up the functional status, we previously already checked up the FFR from the SOC to Lemain, as well as LAD to Lemain. What is the FFR value, the SOC to Lemain?
0.71.
0.71,
Yeah.
Functionally significant. LAD to Lemain?
0.72.
0.71 and 0.72, and the SOC and to main is definitely functionally significant FFR value. Also, we checked the IVUS, pre-intervention IVUS. Could you show us from the LAD to the Lemain? Okay.
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 Distal.
자, 보여주고 있죠, 안에서? Okay. This is the distal part, and the vessel size was the 3.5.
Serial.
Yes. This is a plaque, and there is some calcium. And this is nearly the proximity.
Basically diffuse disease.
Yeah, basically diffuse disease.
Minimal lumen area is clear.
Yes.
Good.
여기 proximity
Good.
나오지?
Looking normal.
Okay, yes, and okay.
Serious
This is
vessel.
region over here, proximity is there is a huge plaque over here.
Lamus.
And also that there is some calcium, definitely proximity is a huge plaque. 썩 아직 안 나와요. Okay, this is a ramus branch, 썩, yeah, we can see there is some severe calcification of a distal lemmain and added ostium. Also, plaque was extended to the lemmain. So at this time, we're gonna check up the IVUS for a SOC, and next one.
IVUS.
Okay, the look, yes, next one. No, sir, previous one. Yeah, okay, looking at the SOC ostium angle is a very acute angle, so sometimes this is the tip in the most of interventional cardiologists to treat the lemmain disease is prefer the Jung-Min catheter, but sometimes such acute angle IVUS wire passage is not easy, and so we decide to initially we select the Jung-Min catheter, but passage IVUS was difficult to pass that region, so we immediately change the XP guiding catheter. XP guiding catheter is also good to do complex lemmain PCI. At the pre-dilation, we check the IVUS for SOC. Okay, can you show us the SOC region? This is the SOC. Initial view 보여주고, initial.
The one looking area.
Yes. This is just the OM branch is over here, and the region is
small.
coming.
Negatively small.
Yeah.
Very small.
Branches.
Yes, branch coming, and there is some. The vessel size was 2.75 or 3.0, and the plaque over here. This is a SOC ostium, and the vessel size was 3.0.
Yeah.
Yes, and you can see another ramus branch coming here, and the very tight stenosis SOC ostium is a 6 o'clock LED wire was coming. This is the distal and main. The main vessel size is 4.0. So region was extended to the distal and main. That is we shows the IVUS and FFR finding, FFR 0.71, 0.72, IVUS image shows the region is prox Suck and also the prox LAD. So I'm gonna the opinion from panel or audience.
So what would you do there from the panel? Any suggestions in terms of how to treat?
Yeah, from IVUS, the most severe lesion localized at the distal left main, which distend into the LAD. Even I was also sure very critical stenosis at the osteosynclasis, but I don't think two-stent technique is required. I still prefer to use the provisional.
But I think confirmed that the LAD and the distal left main is a main problem. The circ to me is relatively small. I mean, it's basically made by two branches or OM. So I will still go for one stent and accept maybe drug-eluting balloon for the osteomosis circ.
Dr. Jung?
After seeing IVUS, actually, circuit doesn't seem that much, 2.5 vessels. So I think focal lesion also on the osteum. So I'll go for single stenting as well. So stenting, yeah.
But the plaque of the proximal circum is not big enough. I think the DEB may be enough to touch the proximal circumflex with a single stent to left main to proximal LAD.
And in general, the final decision is always after pre-dilatation, because you may change the decision after pre-dilatation.
Dr. Takeshi?
Basically, I would agree with Antonio. So I would try provisional stenting, first pre-dilating left circumflex. The just ostium of the circumflex have moderate to severe calcification, so I could not expect the very good result. But if it is acceptable, I would proceed to stenting of left main LAD and look the result.
Single stent?
I prefer single stent to.
But another point there, angiographically caused bifurcation angle between circumflex to left main is not usual. So it's very strange. From our DK5 study, we do have some cases of the prominent stenting technique. If the oscillation circumflex was pinched too much, we need to ballooning, and it will be very, very tough to deploy a short stent into circumflex. So also it depends on the process of prominent stenting technique. Probably if we need to deploy short stent into SIR, it will be very, very tough. Sometimes the stent dislodge or distal dissection, something like that.
You wanna single stent?
Yeah, I prefer single stent, but we have to know there will be some difficulties to use it to transfer to TAP.
All right. What did you do that, TW?
Yeah, right.
To be honest, I want to do the two stents. The meaning is, especially for particular this case, some disease, calcific region of circumflex ostium. If you do, single stent crossover, there are more, complicated things, right? And so I don't want to, complicated one. And so just do circumflex stent first, and then LAD stent is, procedural-wise is very perfect. More easier, more safer. That is my and. Recent data is if you do quite well two stents, high pressure inflation in terms of long term, I think it's too much different, even in the single stent and two stent.
Yeah, I fully agree. As Dr. Antonio Colombo said, don't feel guilty if you deploy two stents for any kind of bifurcation lesion. So, but I mean that before prominent stenting technique, we have to imagine how much the difficulty will be is.
All right, you can do as you want.
Yeah, right. So, some, as discussed, many worldwide famous expert panel, and there are conflicting results from the various panel. Definitely that means this patient is a complex patient. So I'm going to show how do we make a complex patient to simple patient, make it simple. Okay, and next one. So, and after, on the basis of the FFR value and I was finding subaostium was narrowed, we decided to balloon crush. And next one, this is XB guiding casta, and next one. So next one, and this is we exchanged the XB apron guiding catheter. This is 2.5 compliant balloon, and the next one, and then this is an additional compliant balloon, and then shows the looks okay, and then next one, and then on the basis of IVUS finding, we decide to stent size as well as stent length. This is a regular stent, and on the basis IVUS 3.0 is okay, and we are 26 that fully covered that OM region, and this is the exact positioning of the crush portion, and the main branch is a 3.5 non-compliant balloon for the balloon crush, and then here next one, we inflated the SOC 3.0 regular stent, and then next, slightly pull back the SOC stent balloon, and then next, remove the whole system of the SOC, and then the non-compliant balloon 3.5, we do balloon crush here, and the balloon crush is 3.5, 20 atmosphere, next one. This is a 20 atmosphere, next one. Okay, this is immediately after, and you can see how much well the crush the sarcoosteum, and the next one. And this is put the 3.5, 32 on the basis of IVUS. This is how we can exactly positioning of the left main ostium. This is a shallow epicranial view. This is a nice view to exactly positioning the left main ostium. This is 3.5, and the next one. Next one. So this is 3.5, and the next one. Okay, slightly pull back 3.5, next one. And then this is immediately stand the SOC, and then the main system, and then we do additional pot using 4.5 short balloon, non-compliant balloon. Next one. This is our positioning of the pot, 4.5 non-compliant balloon, and next one. This is the pot, and next one. And the pullback, the 4.5, we fully inflated the left main ostium. Next one. And then we try to recross this is the choice PT wire, and this is the step of the recross the circle wire. Choice PT wire is my favorite one, and this is easily past that region and the circle region, and the next. And then we do the small balloon, 1.5.
Excuse
me.
Okay,
okay, got it.
Yeah, can you backward?
Or previous one?
Yeah, previous one.
Yes.
Yeah, the symphysis wire is typically from distal cell.
Yeah, distal cell, right.
So according to our bench test, also from our clinical result, it's not good. We usually recommend rewire from the proximal cell. Because, after balloon crush, you did not perform the first kissing. It's the typical balloon crush. So after standing RAD to left main, there will be a big gap between flat stent and vessel wall. So if you rewire from distal cell, so it will be it's
proximal.
Pretty common to see.
Dr. Shaolin Chen, would you explain a little bit difference in terms of DK crush, right? After balloon crush,
kissing.
And kissing first.
Kissing.
And then
standing
stand under the main,
rewire and then kissing. So immediately, you can see from AP caudal, immediately after balloon crush, there is very severe distortion of flat stent. Can you see very long sleeve of crushed segment of the cell? Okay, so now you will rewire from the distal cell. Go ahead.
Go ahead.
Sorry, Dr. Park. Go ahead.
Yeah, right. So we already inflate. This is additional 1.5, and the next one is some after inflation. Is after final kissing balloon dilation. I'm gonna show how much morphology. If you're gonna do distal cell recross, how much the shape of the IVUS. This is we do, and then we just remain the final step. This is the 3.0 non-compliant balloon.
3.0.
Okay, yeah, 3.0 definitely. Okay. 잠깐만, 천천히. Okay.
So this is also not a problem to use a hydrophilic wire to rewire side branch. So it's easily go goes from distal
got it.
cell. So personally, I prefer to use silicon-coated wire. Good. So this is 3O balloon, 3O and
Which,
balloon.
Professor Shaolin Chen, which wire is the preferred wire for side branch recourse?
First line of wire is a BMW wire.
BMW
Yeah,
wire.
right.
It's a non-hydrophilic
Right.
wire.
Silicon-coated
got it.
wire.
This is the 3.5. 오케이, got it. 잠깐만. 요거 먼저 들어가. 이거 한번 유즈 들어서 안 들어가나 보다.
What's the previous balloon size
Okay,
in
got
single
it.
flash? It's a 2.5 or 2O balloon?
그러면 자, 1번 줘. 오케이. 오케이. 잠깐만. 천천히. Okay, this is a used one.
All right.
Yeah, Dr. S.J. Park. So, cause this is the balloon crush technique, right? So usually we can use 6 French guarding. So why do Dr. Park use the 8 French guarding catheter?
All right. I think it's just a habit. Right. In terms of
Yeah,
all
yeah,
right,
right.
more complex procedures for the main, and sometimes it's we cannot do as we want, and the two stands, another right. So
Oh, I see, to provide a very
Getting-
strong support for IVUS.
you're gonna choose getting smaller.
오케이. 뒤에 스토리. 뒤에는 아직 안 했지? 자, 서커도 좀 하고 나오자. 오케이, got it. The wire here. 자, 잠깐만. 줌 뒤에서부터 하고 나올게요. 조금 더 들어가서. 오케이, 스탠드 부스터. 뒤에 겹치나고. 오케이, 한번 밟을게. 오케이, 자, 고. 자, 노미널만 가. 12.
What size of balloon?
This is 3.0, 12, 14,
3.0.
save, deflate. Yeah, prior stand was 3.0. Okay, 여기서 go. 6, 8, 10,
10,
12,
12.
14,
예.
save, deflate.
Good.
자, LED도 하고 나오자.
예.
So what's the previous balloon size in single flash?
3.0. Okay, go. LED.
This is
6, 8, 10.
3O balloon, right?
Yeah, 3.0, non-compliant. Okay.
And the LED is 3.5.
Right, exactly.
Yes,
Okay,
3.5.
go.
3.5.
잠깐만. 이거 뒤에서 빼서하자. Okay, got it. 자, 서클 go.
예. 서클.
10, 12, 14.
예. 서클.
가.
예. 서클.
Circumflex
14.
first.
예. 14.
Okay, 20.
20.
Okay, deflate. 자, LED. 자,
Yeah, this is alternative inflation, very important for two-step
20,
bending.
20, 24. Okay, deflate. And then we're gonna do kissing balloon dilation. 자, 준비됐죠?
네.
자, go. 10, 10.
10, 10.
Okay, 12, 12.
12.
자, 하나.
So,
둘, 셋.
Professor Chen, you're now doing your DK crush through the radial route now.
Okay.
I mean, you're now doing your DK crush technique
10,
most of the time through the radial.
12, 12.
Yeah,
12.
Okay.
6
하나,
French,
둘,
6
셋.
turn radial.
Yeah, usually
got it.
6 French.
Okay, we're gonna check it up. The angio and IVUS again.
Finally,
After kissing, do you do second part before I was?
Yeah, there is a very nice comment. Is final refart after checking the IVUS, depending on the
That's fine.
the IVUS configuration, we decide additional refart or not. Okay, 자, angio ready?
Shirley Chen, actually, finally we do high pressure inflation,
자, 라이트를
kissing
좀
balloon,
주고.
right? I believe we have a clear effective stand areas, and so you can compare with the DK courses. What's the difference? Right? Over there, still you do kissing balloon first before the stand, and just like this after the stand and the high pressure inflation. So what's different?
Yeah, this is a good idea. Usually for DK crush, we recommend alternative inflation by high pressure followed by kissing. But the problem is that after kissing balloon inflation, because we need to use two balloons, so which will cause irregular pattern at the proximal edge of main metal stand. So second part, in order to make stand a post well,
of stand.
it's only
It's
to
where
repair
closed.
the
There's no
distortion of
dissection.
proximal edge. But your idea is great. We need clinical study to compare.
This is circumflex IVUS?
Yeah, this is circumflex.
Okay, good.
So I think a very good point is how much is some configuration of the subosteum. You know, there is
All
some
right.
concern
You
about
wanna
distal cross.
At least, you know, a stent diameter is more than 2.5 something.
Yeah,
the
right,
stent
3.5,
area is
yeah.
maybe more than 5 millimeters
Yeah,
square.
exactly.
Even angiographically quite small vessels, I think is quite good. You know,
Okay,
stent.
here.
Kiko is, I was
position.
expert.
Yeah.
She's
Suck
sitting
osteum
beside
over
me.
here.
So
Okay.
could you assess
Okay,
the quality of coverage
Okay.
of Foster, Seung-Flash?
Okay, good.
I thought that there is no gap, which you may
Yeah.
expect. So that's
Yeah.
good. Even the wire in the distal, they're not putting out the
Yeah.
stent. So
No
no
gap.
gap.
Oh,
Yeah.
thank you.
And
And
good
thank you,
expansion.
Akiko.
Very lucky,
Okay.
I think.
Okay, yeah. We're gonna show again from the LED to, yeah.
Charlene, to Antonio, what is when we recross the wire, proximal, just Charlene Chen recommend the proximal wiring is better than the distal part of wirings. And theoretically,
I think it depends sometimes of the orientation of the cells of the stent, because theoretically I agree about the difference between proximally and distal, but if the cell of the stent is oriented more distally, it's better to cross more distally. I mean, really to be absolutely sure about the optimal crossing part, you should do OCT to really establish the optimal position, but I think it's too complicated and it's not practical.
Okay,
but
now
if
we
you
see
want
the
to be
edge
precise,
Yeah,
you have to be
some
OCT.
edge dissection. Okay.
That's hematoma.
Akiko, you mentioned about
I
stent
think it's
expansion.
a
is good.
hematoma.
Yeah.
So, Dr. Park, how we can decide the report to
But
perform
you
report
know,
after the patient?
in these cases, if I have to place two stents, now I do almost always TM protrusion, tap. Much easier, less distortion of the stent on the circumflex, and better osteal coverage. I
Okay,
really
this
tend
is
to
coming
tap
of a sock.
almost always.
Okay, this is the coming of a sock, and this is the ostium of a sock.
Main, yeah.
Yeah, this is the main, and we already pulled dilated using 4.5.
And kissing
It's,
balloon, right?
yeah, and then kissing balloon
No, I think
with,
that there is some canina, but that's okay.
yeah, this is exactly matching of main ostium.
How is it?
Okay,
Better.
Akiko, your final comment.
And I think it's okay, but why you protrude such main into the left main? I thought the original osteal LAD was not, osteal left main was not so diseased.
All right.
So,
we-
okay.
Mean,
자, 한번 크리니얼 찍어보자. 자, 라이트를 좀 들어가고 한번 다시
you mean,
찍어볼게요.
Mera, you mean some geographic miss of
Okay.
osteal
아니, 잠깐만,
disease?
잠깐만. 자, 오케이, got it.
It's okay,
자,
it's
and
okay.
you're ready.
Right.
Okay. 자, 풀샷.
Great.
Okay, good. And then we're gonna check up the spiral view.
Spider?
Okay. 갑니다. 풀샷. Oh. Okay, and then
Great.
cranial view.
Good result.
Very nice result.
Yeah.
Yeah, and then okay
I
here.
think the final result is perfect, but personally, I still recommend to use large non-compliant to do
자,
part.
small
Because
dissection
you know,
is
3
okay.
layers of
The previous
stent
one,
in left
spiral
main were not completely crushed.
저 전에 거. 아,
So-
그 다음 거.
Great.
Okay,
All
yeah.
right.
So it's,
Great
I'm going to
cases.
show us how much complex case to make it simple. Yeah.
All right. Thank you. Do you
Thank
want to
you.
move another cases?
Congratulations.
All right.
Okay, thank you.
All right.
네.
Who? Oh, Dr. Lefevre.
Yes,
Yeah. Can you hear me?
yes,
All
very
right.
nicely.
Thank you. Thank you for
How are
coming.
Thank you for your invitation.
Thank you for.
Yeah, so it's a great pleasure to be here in your CAS lab. It's a wonderful CAS lab with a lot of people, very positive, so it's very nice. So maybe, so I'm working with Dr. Lee and Dr. Park, and Dr. Park will present the case.
Okay, let me introduce our case to you. A 61 years old male was admitted for report chest pain. He had a history of diabetes and hypertension. He underwent PCI left main and LAD and proximal shock by crush technique 2 years ago. Recent serum specs showed medium-sized perfusion defect in shock territory. His coronary angiogram showed significant ISR lesion in proximal shock. His previous stent profile is shown below, bottom, and as you see, proximal circum had 3.5 stent. Next. Next.
Okay.
So his echocardiography finding was normal, and FFR value was 0.85, just distal to LAD stent. Next.
Yeah,
Okay.
that's all.
So I think you have a very interesting case. 61 years old, diabetic patient. He had a previous PCI 2 years ago with a crush technique on the left main, and now he's coming back with restenosis. So maybe we can show the first angiogram. Okay, so this is areocodal view, and you can see it's a perfect illustration of what said Antonio during the previous case. When you have a sharp angle like that, the risk of restenosis is very high when you use 2 stents.
Yeah.
So now we have this very tight stenosis. Maybe go to the spider view. And so we have done this is a spider view. You see it's very tight stenosis. It was very easy to cross the lesion. So it's not, I think it's not stent fracture or under expansion.
Yeah.
And we have done OCT, so now we can show you the OCT, because I think it's very important to understand what is the mechanism of restenosis in this kind of case before deciding what we should do.
Right.
Okay, you can do
OCT,
the
please.
So this is a pullback from the circ. You see now the... yeah, so can you go back? Yeah, okay. Do it again, yeah. So pull back for the circ. The stent is well expanded, and we have a very focal and tight stenosis at the ostium, which is neo-endothelialization. So it's a neo-atherosclerosis.
Yeah, right.
Clearly. It's not a stent fracture.
You know, Thierry, is almost always due to hyperplasia. We always try to expand the stent at the ostium of the circumflex very well, because we know. I think it's due to the fact that the shear stress is abnormal.
Absolutely, agree.
It's a physiologic problem. It's nothing
Can you show
to
the
do
3D
with,
reconstruction?
Sorry.
Yeah, I fully agree with you, Antonio. I think it's because we have the carina is not in the center, so we have low shear stress at the level of the circ, and it promotes atherosclerosis. So this is a 3D view. You can see clearly the lesion at the ostium and the stent, which is well open and well opposed in the left main, well expanded also.
Yeah, yeah.
I'm sorry, I think this is not neoatherosclerosis per definition. To say the neoatherosclerosis, we have to have the lipidic plaque, a calcified plaque, or rupture. This is not, it's relatively soft neo-intima hyperplasia.
I think you are right. It's hyperplasia.
The second thing, I do think the opposite side of the carina, I see multiple layer on the circumflex side. Yeah. So I think the crash stent may go back to the circumflex. So that's probably the mechanical issue at the time of the stent implantation.
Yeah, I think
you're right.
2 years ago, the stenting technique was calcium quash, right? 2 years ago, calcium quash 10. So 2 years ago, if you did decay quash, there will be no incident restenosis. Second point is that in terms of the shear stress, abnormal distribution of shear stress, we do have many cases.
Are you sure,
particularly for
Charlene, are you sure that by Deca crush, you will avoid this problem?
Yeah. Almost
I'm not sure.
90% to avoid the occurrence
Right.
of incidence is stenosis.
The OCT finding they still show some, under-expansions compared to the distal, the
No,
proximal?
yes, but I do think not only, no, I think the stent expansion in general, this circumflex is okay by OCT, but at the ostium, I see the crush stent is like folding back to the circumflex. That's the reason we see like 2-3 layer on the opposite side of the carina. So some sort of the mechanical issue happen, or
Mechanical
clinically
issues.
too.
Okay.
Okay, I will just do that.
So Thierry, what's a balloon?
16.
Yep. What's a
So
balloon?
we have a non-compliant balloon, 3.5. This is a,
16.
This is a reference diameter of the stent.
After
And
balloon,
the plan is to, so non-compliant, okay, go
16.
to 16, 18.
18.
After ballooning, could you show us OCT image again? I'd like to see how much they crush in the left man, basically.
So our plan, we have time, huh? So do not deflate too early.
Oh, sorry.
So we have planned, our plan is to do a pre-dilatation, high pressure, non-compliant balloon, check the result, and if we have a good result, we'll do, because I don't like to have 2 layers of stents, so we'll do a drug-eluting balloon.
Great.
But if not, we have to think about another approach. So
Will you choose the cutting balloon or skull flap for the DSISI in the lemon propagation first?
It's great.
can you repeat the question?
Is debugging, means skull flap or cutting balloon first, and then apply the DCB?
Result is not so good. Eh?
No, I fully agree. But of course, you have some carina shifting or maybe plaque shifting.
Maybe try cutting balloon. What about cutting balloon?
Okay, I agree. So we can use a 3.5 cutting balloon.
Okay.
So Thierry,
Or even 4.0 at low pressure.
yeah, could you show us OCT image again?
Maybe trio cutting balloon at high pressure. Trio
Yeah,
cutting
exactly.
at high pressure.
40, please.
So you want to see the OCT now?
Yeah, okay. I'd like to see how much they crush of the circumflex stent in the left main, not in circumflex. Yeah. Could you play OCT slowly in the left main? I mean.
So of
Stop
course,
here.
Yeah,
Stop here.
try to stop.
Could you go back like 3 frame?
Yeah,
this
one
study.
slice backward.
3 frame this study.
reframe back.
This study.
Okay.
Like here, you see the 9 o'clock, there is a strut, and
right.
then like 9:30, you see strut. There is multiple layer.
Right.
So that's opposite side compared to the LED. LED is 3 o'clock, so meaning we have already some crushed strut into the osteosarc, which meaning
Right, that's the problem. For most of classic crush, according to my personal experience, we had to completely crush the 3-layer strut. So from OCT, as Kiko said, 3-layer struts separate each other. So it means there are large gap between first and second layers. So that would be a problem. It's easily to cause abnormal shear stress.
okay. So you saying the crush was not complete at the time of the stenting implantation. Yeah.
Actually,
That's what I want to say.
crush making much more difficult to expand the stent anyway. I mean,
Yeah, I mean, if you do two-stent technique, we have to improve to promote the quality of two-stent technique as high as possible.
So what would you do? Dr.
So the next step is to do dilatation with a cutting balloon. You see, it's not easy to advance.
Cutting balloon?
Yep.
Yeah,
So
we have a lot of friction.
which problems?
Is this the Wolverine or is a classic cutting balloon?
I don't know. Is it a cutting balloon or what is it?
Cutting? What's the name of cutting?
Because the Wolverine is a little bit more flexible.
Yeah.
There's discontinuity between the blades. So it's
just like a stent.
yeah,
It's
like a palmar shot stent instead of a palmar.
They're alive on the balloon. So maybe related with the wire kinking something.
Yeah, this is what I'm
Right.
looking for.
Why not pull out the LED
wire
wire
wrap,
and then
Yeah.
okay, push in for.
Also, I think you can move to epicaudal to see if there is angulation between guiding and the left main.
Shall we move to caudal?
It's very strange.
Okay.
Okay.
Do you want to caudal?
Oh no, it's okay. We can leave it like that.
Okay.
But you see, we have a lot of difficulty with the cutting.
Yeah, cutting is
Great.
not.
Very strong team,
Good.
very famous team.
Maybe doing some inflation now when it's right there, facilitate progression.
Is it the cutting balloon?
Good.
Inflate a little bit.
Cutting has a very large profile.
Okay. Do you want to?
Okay.
Okay.
All right, slip first and then
Five.
push in again.
So, Dr. Antonio Colombo, when you use a cutting balloon for incident restenosis for such kind of cases, do you need to wire RAD again before inflation?
Before inflation, why not? That there is more. To be
No,
honest,
we are not
in
able
the-
to go
the-
Okay,
we don't worry about compromise.
Made
of
some
LED,
progress.
right? However, in the later,
No, it's not moving.
Okay.
almost there.
So
it's a 3-0 cutting balloon, right, Thierry?
4-0.
4-0. How many pressure?
5 pressure.
Okay.
Low pressure.
But we're not able to cross the strut because probably there is a lot of metal here.
There is.
Right, it's,
Yeah. So what we can do is to use a 4-0 non-compliant balloon.
Okay, 4-0.
Can we see a picture now?
Or how about other type of scoring balloon? For example, the Scoreflex, the NSG, Angioscope, and that sort of scoring balloon. Do you think it's help?
Okay.
It's good.
Scoring balloon. I don't know. Do you have scoring balloon?
Okay. Antonio, do you, in fact, do you believe
Okay. We
plain
use another
balloon,
wire.
Okay.
plain balloon dilatation and a cutting balloon for the instant restenosis?
Oh, I think a cutting balloon is much better.
See, we have.
Much
No
better
question,
for
much better. But you have to go to very high pressure and to use the appropriate size balloon. I will go maybe with a 3.5 high pressure balloon and then go again with a cutting balloon.
okay.
I think you really need to have an optimal result because it's otherwise the restenosis rate is prohibitive.
4.20.
I mean, when you have this ostial restenosis in the stent of the circumflex, the only way to prevent restenosis is not to do angiographic follow-up. That's the only way to prevent restenosis.
Yeah, but the patient was symptomatic, Antonio.
This is very old data, right? In very first data we have, actually we compare with a plain balloon dilation, right? And cutting balloon before the brachytherapy. It's an old story. Actually, we didn't find any, to be honest, no difference based on the data. However, morphologically, I think it's believable. Cutting balloon look better than the plain balloon.
You know, if you do long-term angiographic follow-up, the restenosis rate for instant ostial circumflex restenosis is close to 100%. You just have to wait.
Yeah, I think you have used a non-compliant balloon and a cutting balloon. So I don't think scoring balloon is necessary for this case. You can go directly to the use of DCB, drug coating
So
balloon.
this is scoring balloon. Okay, perfect.
Scoring. Okay.
Okay, so we'll use a scoring balloon, 3.5, relatively high pressure.
There is some shift to LID. So
Yeah.
SJ, do you routinely use the combination of cardiac balloon and scoring balloon? Just one, right?
Just non-compliant balloon.
It will be nice in this situation to do orbital atherectomy.
Yeah, it's a good point.
Orbital atherectomy is very dangerous for these steep curves, but when you have a stent there, it's safer and really does a lot of debulking when it's steep curve. You should not do it in native, but for instance, restenosis, I think is fine. And maybe just to be safer, instead of activating on the way in, you activate on the way back.
What size? Scoring?
14. 3.5. 3.5.
Okay, 3.5. Okay, full dilated.
Usually it's soft, then the cardiac balloon.
Yeah, there are 2 points I'd like to make.
Okay.
Point one is that my colleague Dr. Jung-Min, I do believe he presented his pilot study yesterday during TCTAP to report a very short result to combine the use of scoring or cardiac balloon with DCT for de novo lesion. Second point is that for any kind of incident restenosis, we have to identify the etiology for the incident restenosis. For this patient, I highly recommend to use at least 4.5 or even 5 non-compliant balloon to dilate from the very proximity of the cell to the left main. Yeah, to make sure complete crush. This is the key.
What I'm talking is there are some combined, still on the expansion and intima hyperplasia. So I want to choose the maybe 3.25 or 3.5 non-compliant balloon, high pressure in 25,
And then we'll use 3.5 semi-compliant for the LED.
Yeah.
15, yeah. So Antonio, the next step now is to use a drug-eluting balloon.
Okay, great.
Then we'll do a kissing balloon and assess the result. If we are happy with the result, we'll stay like that. If not, we'll have to stent. But I don't like to put 2 layers of stents
At the end,
if I'm not obliged.
In this situation, I like to do a kissing balloon with 2 drug-eluting balloons.
All right.
Yeah, I always do kissing balloon with 2 drug-eluting balloons.
Yeah, but you know, Antonio, there was no lesion on the proximal LED.
Yeah, but you know the trauma and everything. It's okay. I mean, it's really. I don't have any data, but that's what I do. Kissing balloon with 2
But Thierry, if you look at the LED ostium, you have already modified a little bit the plaque. There is new plaque shift at the ostium, so I would definitely treat the LED again, also with a drug balloon, because it's modified.
All right. Kissing.
Okay. So long inflation. Go ahead.
Yeah. So just a few days, FDA announced a very high mortality of DCB for peripheral artery angioplasty. SJ, do you have any comments about the routine use of DCB for coronary artery disease?
Long inflation is very important.
Yeah, no comment.
So now we can prepare the 3.5 balloon for the
semi-compliant.
For the LED.
Okay.
Because what we have done by treating the ostial circ, we have done plaque shifting or carina shifting or both. So I will relocate the carina in the middle. So I think this is one of the problems with the Deca crush, is that the carina is not in the middle. It should be. So that's why you have area of low shear stress at the level of the circ, and which promote intimal hyperplasia.
40 seconds, 50 seconds.
Okay, deflate. So we have done a long inflation, 45 seconds.
Saline.
Now you can give me the balloon.
Yeah. 3.5.
So what will be your advice if we have not a good result after the kissing balloon inflation?
We prepare the non-compliant.
Semi-compliant. 3.5 semi-compliant.
We don't have a 3.5 semi-compliant, so 3.5 non-compliant. How about?
No. Or 3.5 20 or is it? Okay, we will try.
Because TCB is not a non-compliant balloon, so you will use the kitchen TCB balloon first, then the TCB.
Okay. So this one is
usually we perform kissing firstly and then DCB. Dr. Chen, is that your question?
I will use a non-compliant balloon kitchen first.
You know, Thierry, I think we should do a retrospective study of all in-stent restenosis of the ostium of the circumflex and see in the long term what happened, different treatment, but to collect like 200 cases, 300, big numbers, will be a very nice study. We may learn something.
I agree. So Dr. Han, just before the case, told me that he's already doing that in Seoul, looking at the data. I think we can have a collective data from different centers. I think it will be very interesting.
I think it will
can
be
you
very
make a
nice.
test?
Testing.
Okay. So I will do the kiss in the polygon of confluence in order not to touch the proximal part. Test.
Testing.
Okay. So we can inflate the circ first. Okay, go to 14. Okay, 14 in the LED.
Ready? 14.
Ah, it moved. Okay, deflation. So we'll go to lower pressure. Okay. So 10 in the circ.
10.
10 in the LED.
LED. 10.
Okay. Okay, stop.
하나, 둘, 셋.
Yes, thank you.
I think 6 in already is enough. 10.
Okay, we can make injection like that.
Okay.
Okay.
Great. Quite acceptable.
So do you want to see the OCT in the circ or different view?
Yeah, OCT from both sides. Also, we want to know 1 year follow-up in next TCTAP.
Yeah.
So you want to do, Dr. Lefevre, you want to do OCT?
Yeah.
All right.
We'll do OCT now.
Okay, and so we want to move to another CAT lab, and we'll be back soon, right?
Okay,
And so we're going to
perfect.
discuss the
Okay.
OCT findings too. Great, result.
Perfect. Thank you very much.
Okay, Dr. Han, please. Another.
Afternoon.
Okay.
Dr. Colombo.
Can I hear you? Can you hear?
Yes, I can hear you.
All right. So why not?
Okay.
So introduce.
This is
your
Dr.
team
Kwon.
first.
Professor Osung Kwon. This is Dr. Park, my fellow. Could you introduce my patient?
Okay. Good afternoon, everyone. The patient is a 67-year-old female, was admitted for April chest pain. He had a history of hyperlipidemia and tachycardia arthritis involving both subclavian artery. Coronary angiogram showed the significant stenosis at left main bifurcation and total occlusion at the proximal part of the RCA. She couldn't undergo CABG due to stenosis at the bilateral internal mammary artery disease, so we decided to perform PCI. So 4 days ago, we did the RCA first. Next. Yes, the presentation is a stable angina. Next. So echo show normal, and we can explain the left status. Next. Next. Okay, so we're gonna deal with the left main bifurcation disease today.
Several days ago, we already treated the RCA, also a CTO. So our CTO specialist, Dr. Lee, already opened the RCA CTO. And today we are focused on the left main only. This left main bifurcation, could you show us another view? Involving the left main bifurcation, and next. And diffuse LAD disease, and diagonal ostium disease. So initially we checked the FFR. Could you show us the FFR? Could you show us the FFR? Okay, FFR value is far distal LAD is 0.75. Just below the left main bifurcation, 0.72, and greater stable occurred in the left main bifurcation. So I think the left main is a very tight, very significant, and associated with a very diffuse LAD disease. So I want to focus on the left main bifurcation first, and if possible, I'd like to measure the LAD. Hopefully, I'd like to treat diffuse LAD disease by medication.
Okay, so
what is your?
I think the syntax score is 47, right?
Yeah, 47.
A good candidate for surgery too, right?
Could you show us the RCA? The
RCA intervention?
No. Could you show us the subclavian? Both subclavian arteries totally yes. If this patient did not have Takayasu arteritis, even though high syntax score, I think personally I like to treat this patient by PCI.
Because the patient has Takayasu disease, did you measure CRP or any other biomarker of inflammation?
Is normal. Yes, normal. So not active status.
Okay. Another question is that did you prescribe immunoinhibition therapy?
No, not yet. Because Takayasu arteritis is not active status, so the steroid or other immunotherapy is not necessary.
Okay. So what is the next?
So, yes, through bifurcation, could you show us the IBUS? Yes, this is LAD pullback. Skip the LAD and could you focus on the left main? Okay, no, okay, start here. Just this LAD ostium, normal looking area. This is the left main bifurcation, very tight.
Very tight.
Yeah.
Lumen area is 3 or something, right?
Yeah, 3 less than 3, yeah. Vessel is very big. Vessel size is more than 4.
Vessel size almost 5.5?
Yeah.
5, more than 5.
Could you show us the circumflex? Yeah, run please. Okay, circumflex is at least 3O. And diffuse disease, very proximal portion of circumflex ostium. Stop, please.
Very much disease, right?
Very much disease. So simple crossover. May this patient have high risk of circumflex jail. So I like to start with the two-stent technique. Sometimes the two-stent technique is simpler than the crossover technique.
I agree.
I have a question for Dr. Kimura. Would you, if you have this case in Japan, would you consider to prepare the lesion with directional atherectomy?
Personally, I'm not. I don't favor directional atherectomy, but some Japanese physicians will favor it. Particularly, this patient has a relatively mild calcification, considering the etiology of Takayasu arteritis. So some interventional cardiologists in Japan will consider.
I think this is an ideal case. It's not very calcific, a lot of plaque burden, large vessels. I think you get really an excellent stent result if you remove the plaque with
LAD
DCA.
is 4O balloon, circumflex is 3.25, 15 stent. Test, please. Circuminflation. 3.2, 12.
I personally would favor culotte in this situation. The angle is quite good. Sizes of the two
16,
vessels
18,
are similar.
I would go for culotte.
3.4 deflation. And one more high pressure.
14,
14, 16,
16.
No indentation. Opening the circumflex also is a very important deflation. Okay, I'd like to remove a whole system of a sock.
Yeah.
And test, please. This is the 4O.
Great.
10.
네. 10입니다.
Usually, before we remove stem volume wire from some place, we have to take angio to make sure no complication.
Thank you. 10.
10 달라졌습니다.
So is this the
12,
non-compliant
13,
balloon?
14. Yes, non-compliant balloon. 14, 16.
16.
So whenever you do the balloon crush, use the non-compliant balloon in
Yes,
Asan Medical
right.
Center?
Yes.
Yes, 10.
10. 네.
So
Deflation.
what is the stand?
This is giant stand.
Giant,
3.25. 10.
We cannot see clearly.
네.
14, 16.
16입니다.
Deflation. And please give me the stand for LAD.
What size?
4O stand.
4O stand. Length, right?
Length is
랭스가
Dr. An,
18.
Dr. An,
Yeah.
could you
Yeah.
take angiography before studying LAD?
Yes, I will.
ready?
Test. Okay. Test, please. Test. Okay. Test, please. 10.
가겠습니다. 10입니다.
12.
12.
Great. So
deflation.
again, Charlene, we are discussing about distal part, proximal part, right? And however, look at this. I want to just say, we don't have data yet, right? After the balloon crushes, the proximal stent is very minimal part of a crush like this, right? Angiographically, we're going to confirm a little bit distal. However, angiographically distal, however, sometimes it's a proximal distal. It's not, big difference. It's not a big matter, right? So I think many intervention is talking about, we have to recross the wires, proximal and distal. To be honest, in fact, we didn't, care about that one. After the balloon crushing, the proximal part is very minimally crushed, and recross the wire is always, bias from the visual things,
16,
right?
18.
Yeah, it's actually after balloon crush, the proximal cell is different from the original proximal cell. Proximal cell has been crushed, so it's between proximal and the middle cell.
This is 24, 26, deflation. So before the rewiring, I think the left main LAD stent optimization is the most important part.
So what size?
Ready? This is 4O. Ready?
4O.
High pressure balloon.
High pressure balloon.
Okay.
Some, all right, corona shift
Yes.
to the
So-
LAD to the circumflex osseous part. However,
So check the IVUS. If there is a suboptimal LAD stent, and then after correction, I will do the rewire to the circumflex. This makes the easy to rewire to the circumflex.
Dr.
So,
could you tell us how to define the position of left main stent? I mean, if we only use spider wheel or epicaudal, so probably the protrusion into the aorta will be a little bit long. So sometimes
Yes, I think so.
Yeah. Can you tell us your experience?
Yes, in this case, I don't care how protruded to the aorta because we have to make a distal landing zone.
Distal landing is good.
Yes, the distal landing is more important because my stent is implanted more digitally. There is some plaque. So I only focus on the distal landing zones. I don't care proximal landing, how much protruded to the aorta. But usually, I will use the multiple projection to make sure the ostial stenting.
Good.
Okay, I covered the
2 millimeter.
ostium. Yeah. And could you show us the IVUS? Main is well expanded, so no further balloon dilatation necessary. Then now I try to rewire. Wire, please. This is used one previously. Hopefully, not difficult to rewire.
What wire?
Okay.
Used one. It's Hyun? BMW? Hyun?
It doesn't matter what wire it is.
So please give me the 3.25
NC.
And 4O NC balloon, please.
4O.
Yes, for
What of the
LAD.
circumflex size? 4 2?
3.25 high pressure.
3.25. Great.
Yeah.
I like that one. So in the high pressure, 3.25, almost 30 atmosphere. It is almost 3.5 something.
Sometimes the small balloon is necessary.
It works.
But in this case, look at. Okay, I will. This is U1, so I hope U1 can passing through. 4O, please.
In flip first and
So it
Yes.
it looks like the balloon was stuck.
Yeah, I know. So
I-
this is 3.25.
You know,
3.25.
I think we need to do a prospective randomized study when we use two stents in the left main to debulk the ostium of the circumflex. To
Great
to
idea.
really debulk with DCA or
Roda.
DV.
rod ablation is
Okay.
not the debulking. Rod ablation is just plaque modification.
12, 13, 14, 16, 18, 20. Deflation. 20, 3.24. Okay. 20. Deflation.
Okay, great. 3.25, non-compliant high pressure for the
20 again.
circumferential stent
Circumflex.
force. And then kissing balloon.
Yes, final kissing balloon.
And
Deflation. I can finish bifurcation within 20 minutes.
So,
Okay, test it, please. Okay. Final kissing. With 10.
great, good.
10, 10.
하나, 둘, 셋.
Kiko, did you find some problem with the circumflex stent struts? I mean,
하나, 둘,
around
셋.
12 o'clock.
Okay, we'll see that.
You are sleepy.
One more.
하나, 둘, 셋.
Did you find some problem with circumflex stent struts?
12.
Deflation. 하나, 둘, 셋.
You see, around 12 o'clock, a few struts are uptick to the vessel wall.
So this is 4O stent. It's a kind of part. 20.
가겠습니다. 20.
24.
4.
28.
20입니다.
Great.
Deflation.
포스터스.
No problem.
Balloon perforation.
No problem.
Today I made many balloon perforation.
What's a balloon?
볼륨 네임이 뭐야? 볼륨 네임. NC 트렌.
Angio, we have
Yes, just a moment.
2 minutes.
We
I
should
remove the
think
balloon.
of flaring the ostium a little bit more, I think, because the next one who has to treat the circumflex stenosis that we've just seen in the other case doesn't want to get entangled in the struts. So I would
Ready?
suggest always to go to a trumpet ostium.
Just a moment.
Use a short
Ready?
5-0 or something.
Ready?
Angio. Great. I like it.
So I like to see the IVUS. If we have time.
And geographically,
Why not?
ostium flex was not fully expanded, right? Akiko, do you have any more comments? No?
If there is just some under-expanded area, I will apply the again high pressure again. Okay, this is the LAD. Learn, please. Okay, this is just above the first diagonal branch.
You know, but there is too much plaque that prevents full stent expansion. You know, it's like putting shoes with 3 pairs of socks. If you don't remove the socks, the shoes
Almost
don't go in.
35 minimal stent diameters, maybe more than 10 millimeters square. But
I think it's enough big.
center position is good.
Okay, stop please. I'd like to see the sulc ostium.
Okay.
This is the main interest. Okay.
Good.
3.25 I implanted and I applied high pressure using 3.25 high pressure. Not touch the distal part, but the
Distal
stent
landing is
expansion is
good.
good.
I think it's almost perfect, right? 3, 5.
I applied the high pressure here on more than 24. Look at the ostium. Okay, what do you think
good,
about
good.
it?
It's okay, but I think symmetry index at the ostium flex is a little bit small.
Look at the symmetry.
It's better
You
than
say
angiogram.
okay, is okay.
Better than angiogram.
But I think it's
Ready?
quite good,
Ready?
right? Not much problems. So great. All right.
That's good.
After, you may need another long stent for the LAD section, right? In the later.
Ready?
Anyway, for the focus on the main intervention is really perfect,
Not bad.
right? All right, you wanna?
you.
Thank you for. All right, we're gonna move Dr. Lefevre. So we just discuss about All right.
Okay, so maybe we can go back to what we have done. So we have done the OCT in both branches.
Yes.
I will show you. Can we see the OCT?
OCT
please?
findings.
Previous one.
No, OCT that was done the previous run. LAD and circ, yeah. So this is.
This is chapter artifact.
Yeah.
But that's okay. That's okay.
So this is a pullback from the circ. You've seen that there is a large lumen.
So this is exact.
Yeah.
This is ostium.
Yeah, exactly.
Is it good?
What is the lumen area inside of the tissue?
The lumen area at the ostium.
This mean just
Here.
all right, great.
Yeah.
Here.
5.5. I think we have to be careful to understand this kind of picture. It's chart artifact, so we underestimate. But at least
That's good.
Yeah, not so bad.
Yeah. And can you show now the LED?
Quite good, acceptable.
No, it's not the.
Here we see like tissue or a little bit more proximally. 9 o'clock, that's like the feeling defect which we see by angio, and also the 6 o'clock. But still remains okay.
So looking at these two pullbacks, we decide to do a post-dilatation with 4-0 non-compliant in the circ and 3-5 in the LED. And okay, so this can you go back? Okay, so this is a result that we had before the pullback in both branches. You see that there is some protrusion of plaque in the LED ostium and some residual lesion. Then we have done post-dilatation with a 4-0, you can see. A kissing balloon with 4-0 and 3.5 several times because the balloon was moving. Next. And this is a final result.
Great.
Maybe I can
recheck, please.
I can do another one in the spider view.
Congratulations.
But I think it's clearly better now. Okay. Ready? Okay, so here's some haziness in the circ ostium.
Yeah, but it's done mad. Very,
Hold on. Right.
very severe
Oh,
plaque burden. It's a good result. So, Dr. Antonio Colombo said, wait.
Yeah. Of course, the other option is to restent. It's very easy to do that, but I'm not sure that it's the best option for this kind of situation. I will. We had the catheter in place, so I will do another view like that.
How about Dr. Thierry?
Yeah.
How about the applied FFR to the LAD or circumflex?
Oh, take time.
So, what do you think?
I think it's good angiographic result. All right, so when
check another view.
Yeah.
Any other comment on this, Caroline?
Was there already the drug-eluting balloon applied?
I would accept this result. I mean, I'll not put another stent here. I'll accept this result because it's suboptimal, but it's okay.
I think it's good. The stent area is more than 5.5, something. It's not suboptimal.
Low ischemia 3,
all right.
Nothing. So
All right.
I think it's good to leave it like this. If patient will be coming back with restenosis again, then that could be another option, I mean, to put another stent. Now, if you are putting a stent now, he will not have any other option there.
All right.
No, I
Based on
agree,
any index-wise, I think it's almost optimal result. I personally, I think so, right? We don't want a perfect, dilation is 4 or something like that. So, however, functionally, I think it's quite enough, good result.
Yeah.
All right.
So I fully agree with you. I think it's the best that we can do with without a stent.
Right. Exactly.
And I would like again to thank you and all the team in the room for the very helpful.
Great. Thank you for
Thank you very
great
much.
cases, live demonstration. Okay, it's just on time. So After this session, we're going to move to the future lecture. Gregg is over there. All right. Tomorrow, anyways, we have prepared more than 10 cases of the main disease, main by PCI. So don't worry, maybe you can enjoy tomorrow more. All right. Gregg, our great friend, master FFRCT to guide the revascularization decision, the decision trial, please.
Great, well thank you, SJ. So what's really remarkable that as good as we've gotten in the cath lab, we're not very good at diagnosing whether or not patients will actually have coronary artery disease. It's still the truth that about 70% of patients with suspected coronary disease that we take to the catheterization lab have non-obstructive disease. This relatively recent study from 400,000 patients in the United States, and you can see these patients suspected coronary disease, regardless of whether they had atypical symptoms, typical angina, or no symptoms. Obstructive coronary disease at best is 50%, even if their stress testing is strongly positive. So I can tell you as an interventional cardiologist, if I never do another normal cath in my life, it would be too soon. And of course, this increases expenses and there are some complications. In addition, there are other issues that we have. Heart team decision making is recommended for patients with complex coronary disease, but detailed angiographic and anatomy and lesion-specific physiologic significance is not usually known until after invasive coronary angiography. And patients and docs, of course, would prefer ad hoc PCA when it's feasible. So it's, if you take a patient to the cath lab, if you find complex disease, you'd rather not take them off the table and then have a discussion with the surgeon if you know you're going to end up going back and performing PCI. And finally, since FFR or IFR are usually done at the time of PCI, stent decisions are usually made on the fly. And that usually works out okay, but sometimes it can be very difficult. If you have, let's say, long diffuse disease or serial stenoses, it can be very hard to plan right there at the cath table to decide what the optimal treatment is for that patient. And yes, mistakes can be made. So when we think about what we want to know both anatomy and function. And there are non-invasive ways we can tell anatomy, such as with CT scanning or MRI, and we can tell function, of course, with a variety of stress testing. Then there are invasive ways where we can tell anatomy with cath and function with IFR, FFR, etc. But we do have one test which is getting increasing attention in the United States and elsewhere that will tell us both of those, and that is FFRCT, or CT-FFR. And so with this, of course, it takes the information, the anatomic information from the CT scan, uses computational hydraulic formulas based on the amount of myocardial mass each vessel subtends, and it can calculate on a pixel-by-pixel basis what the predicted FFR would be. And you get these color-coded maps that you can rotate in 3 dimensions, and you can see exquisite detail here. So basically, you can see here's a right coronary artery with an FFR of 0.83 all the way down at the tip. Here's an LAD with an FFR of 0.57. So this has been studied extensively and compared to other invasive tests as a prediction for FFR, it seems to be the most accurate test with the highest sensitivity and specificity. Most recently, the Pacific trial was done. This was 208 patients who underwent CTA, SPECT, PET, and routine 3-vessel FFR. And so as a comparison of invasive FFR, you could see that FFRCT was better than PET, better than routine CT, and certainly better than SPECT in terms of area under the curve. So it's really good to predict what the FFR will be in the cath lab. Now, there have been studies therefore been done to suggest or say, can we defer going to the cath lab in patients with a normal FFRCT? And the platform study was a non-randomized trial that took 584 patients with new onset chest pain who prospectively assigned them in 2 groups, either undergo usual testing, that is go to the cath lab or not according to your stress test, or FFRCT guided testing in different time periods. And in the usual care group, 187 patients went to the cath lab and only 27% actually had obstructive coronary disease, where in the FFRCT guided group, you could see that in 61% of the patients, no angiography was performed. They found 27% again had obstructive disease. There were a few false positive FFRCTs, but they basically deferred unnecessary angiography, in this case in 83% of cases. Now, they followed these patients. This was not a randomized trial, and it wasn't powered for MACE, but they followed the patients for a year. They saw very low rates of MACE in both groups, including in the patients who were deferred. They had similar radiation use in both groups, despite the fact that you had CT-FFR in all those patients, and total costs were approximately a third reduced by avoiding angiography. Another thing that you can do with this technology, which has recently been submitted to the FDA for approval, is what's called virtual stenting, or by use of the interactive FFRCT planner. And that is, you can take a stenosis and then mathematically model what would happen to it if you put a stent in it and basically eliminated the stenosis, and then calculate the new FFRCT. So here, for example, this is an invasive case, and here you can see there's moderate diffuse disease in the proximal mid-LAD. The baseline FFR is 0.68, and here, after putting in stents, the FFR is now 0.90. So here was the FFRCT, which predicted an FFR of 0.72, pretty close to 0.68, and here's what the virtual stenting looked like before the case was even done. It predicted 0.86, and it got 0.90. So you can use this in interesting ways. So here's a right coronary artery that's got diffuse disease, perhaps 3 moderately focal stenoses. And you can see the FFR is 0.64, again, the FFRCT. So if you find this in the cath lab, what are you going to do? Are you going to stent the whole thing? Are you going to do spot stenting? How are you going to decide which ones to stent? Well, let's do some different testing. Here's one FFRCT plan with the interactive CT planner where we just stent proximally. And now this will bring here the FFR down to 0.79 distally. Not bad with just one stent, but maybe not yet perfect. Well, here, let's try this. Okay, maybe we should also treat that lesion. So let's put a second stent in. Now this brings the FFRCT down to 0.83. We're pretty happy. What will happen if we treat that third lesion? Well, if we treat the third lesion, now the FFR is a tiny bit better, but it's only 0.85, not a whole lot different than 0.83. Well, let's try a fourth possibility. Maybe we should just treat the proximal and the distal and not the mid. Now we're at 0.81, not as good. So now we can choose this one as probably the best. This that minimizes the amount of stenting and gives us a really good overall FFRCT. And so this is maybe what we're going to do when we go to the cath lab. And in fact, having this ability to plan before you go to the cath lab may be better than making decisions in the cath lab. So here's a case where you've got 2 lesions, proximal and mid-LAD, and you can see what the FFR measurements are, 0.77 distally, and you can see the drop in FFR across these 2 lesions. So the operator said, well, look, it looks like it's more severe there, and angiographically it's more severe, so he stented the mid-LAD lesion, and the FFR is still 0.78. It didn't really get much better, and you can see the proximal lesion FFR goes up because now it's not flow limiting, now it's more flow limiting proximally, and so he had to put in a stent proximally. You get an FFR 0.85. And interestingly, if you looked at what would have happened with the virtual stenting model, you would have gotten 0.78 distally. If you stent the mid-LAD, you get 0.79. It told you that wasn't the right thing to do. It said you would have had to stent both of them to get to 0.85. On the other hand, it also would have told you that all you had to do was stent the proximal lesion, because if you stented the proximal lesion, you would have been at 0.84. So you didn't have to stent the mid lesion. So having all this information before you go to the cath lab can be very useful. It can tell you whether or not there's disease, do you even have to go to the cath lab, and if so, is it single, double, triple vessel disease, how many stents will you have to implant, maybe it will tell you whether you should do PCI versus surgery. So with this in mind, we've designed, and later this year we'll start the decision trial. And this will be a multi-center randomized trial in 5,000 patients who are troponin negative in whom angiography is suspected for planned coronary disease. All the patients are going to have a study FFRCT, and this will stay blinded in the standard of care arm. The standard of care arm will go to standard angiography, where the FFRCT arm will have their FFRCT unblinded, and a heart team will meet to look at the FFRCT results. Now in the standard arm, they go to the cath lab, and if there is sufficient disease that they need to have revascularization, they'll have FFR or IFR guided revascularization, or they'll go to surgery, whatever is dictated. In the experimental arm, if the FFRCT shows either a plaque rupture, a left main stenosis, or an FFRCT of less than 0.8, then they'll definitely go to the cath lab. The heart team will have met before and will have decided whether or not the patient should have PCI or CABG. It'll just get confirmed by the cath, and then that strategy will be followed. If the FFRCT is greater than 0.8 and none of these are present, then cath will be deferred for medical therapy. And there are some intermediate scenarios which will give the operator some leeway to go to the cath, for example, an FFRCT of 0.81 to 0.85 with typical angiography. Patients will be followed for 5 years. The primary endpoint will be 2-year MACE. The goal is to show non-inferiority for MACE and superiority for combination events, including reducing costs, improving quality of life, and being able to defer catheterization in probably about 2/3 of the patients. So in conclusion, CT with FFRCT provides data on coronary anatomy and physiology, which more strongly correlates with invasive FFR than any other non-invasive diagnostic test. Non-randomized studies suggest that deferral of invasive coronary angiography in patients with a negative FFRCT may safely obviate unnecessary angiography. The FFRCT planner has been developed to allow the local heart team to reach revascularization decisions prior to angiography and provide interventional guidance for PCI procedures without the need for invasive physiology. And the decision trial, which will start later this year, is a large-scale randomized study which will determine, one, whether FFRCT guidance with the use of the FFRCT planner in patients whom angiography is otherwise planned may safely defer unnecessary cardiac catheterization procedures while improving overall clinical outcomes and reducing costs. Thanks very much.
Thank you, Greg. It's a really comprehensive talk, and so you want to move next. Would you, Antonio?
I think we go to the debate. We have a very hot debate, a very important topic about CTO. We have two very eminent lecturers. Gerald Werner will defend that all CTOs should be open because we are born with arteries open. And S.J. Park will take the opposite view.
Thank you, Antonio. Well, of course, someone who is pro-CTO, he will never tell you that all CTOs should be opened. That is unreasonable. We don't have 100% and 0% approach to medicine. But there are pros and cons, and I want to emphasize what is in favor of doing it. What we need for the indication is proof of viability. And what we need is a positive balance between the patient's impairment by the lesion and the risk of the procedure. So here I bring you an example of a patient with an RCA CTO, with nice collaterals, and an LAD CTO. And of course, both are CTOs, but I will treat only one. Based on the CT of the MRI, we see that there is subendocardial scar in the inferior wall, but there is complete scar of the apex. So certainly, according to this, I will not do all the CTOs, I will just do the right. Well, we recently got results of a randomized trial that showed into improvement of LV function by doing CTOs or just referring the patients to OMT. This Revasc study showed that there was actually, after 6 months, no benefit. However, the problem of such a trial is that the ejection fraction was 59%. That's normal. You cannot improve something that is normal. That's shown already many, many years before, not only by us, and also by others. If you look at patients with normal LV function, of course, there is no improvement also in regional wall motion. But if you have global and regional dysfunction, then you will have changes. And if you look at the CTO dimension, you will have patients with regional dysfunction, with normal function, of course, nothing will improve except symptoms, and with severe global dysfunction. And if we looked at these patients many years ago, then of course there are some that will not improve, and we will have to find out and define these patients so we don't do harm to them. But we see a large number, even from the most severe dysfunction, that will improve to a regional or even complete normal LV function. That can be done by MRI. Now, in our days, the complete, the severe regional and global dysfunction is becoming less and less because of acute STEMI treatment. So we don't have the post-infarct LV dysfunction that we had 15 years ago. Now we often find patients with very good normal function and some atypical symptoms. This guy, for example, he was a soccer player and he had limited physical ability, who moved from the outfield to become goalkeeper. And the reason was he had a lot of CTOs, as you see here. So what we want to do for this patient is to let him lead a symptom-free and unaffected life, get him back on the field. Goalkeeper is boring, because his collaterals are not good enough. This is an anecdotal idea of many protagonists of conservative medical treatment for CTOs, because they have collaterals. But we have shown many years ago that when we did measure FFR distal to a CTO, that there is actually no protection by collaterals under the ischemic condition. And indeed, we see an improvement of quality of life. The recent open CTO registry, which showed in very consecutive and severely impaired patients, severe impairment shown by low scores of angina frequency and physical limitation, that we have a consistent improvement. But one thing is also important, it's not only angina, it's often dyspnea. Most of these patients come with dyspnea. Maybe they have had their turn through a pulmonology department before they end up at the cardiologist. The EuroCTO trial published last year showed in a randomized fashion between OMT and PCI that indeed the PCI was superior in improving quality of life, angina frequency, and also to a certain limit, the physical limitation. And this was at a high level of significance. We had more patients free of angina and better physical limitation after PCI as compared to OMT. And actually also the Decision CTO trial showed an improvement like the open CTO registry. The only thing in the Decision CTO trial that there was a considerable improvement in the OMT arm, but we all know that the OMT patients got a lot of non-CTO PCI. That was one of the drivers that also the improvement of symptoms was visible there. But what we see in randomized trials as compared to registries is, of course, that we have lower symptom scores, so more symptomatic patients in registries as compared to randomized trials, because it's a selection bias. You never randomize the really sick patient. He will refuse, or even the doctor refuses. But let's have a brief look what would mean medical therapy to a symptomatic patient. Of course, we know that, for example, with ranolazine, we can improve symptoms, but to what extent? You have to take twice ranolazine a day to improve your angina frequency from 3.3 attacks per week to 2.1. And you have to take this for all your life, maybe until the day finally this lesion causes an infarct and you get no symptoms anymore. So this is also something that has to be considered, taking beta blockers, nitrates, calcium antagonists with a lot of side effects for all the time. On the other hand, if you open a CTO, here is a nice small study by Carlo Di Mario's group, successfully treated CTOs 85% of the patients had no angina during the week. Come back to this patient. We treated the patient, of course, and, well, I must confess he didn't go back to the field. He still stayed in the goal. He remained goalkeeper, but with open arteries. So we can show that we make people lead a symptom-free and unaffected life. Can we show that people live longer? Do we have to show that? Of course, we know from the syntax study, syntax was presented in one of the previous sessions today, that incomplete revascularization is a major factor of survival after PCI or CABG. And in PCI, the incompleteness of revascularization was mainly due to CTOs left over. On the other hand, we know that if we look at large registries, there is a survival benefit here, for example, from UK. But you needed 14,000 patients to prove this because it's stable angina with a rather low mortality. Now, what are our contemporary data in respect to this survival curves? The open CTO in US shows that their mortality is even higher because, for example, 40% of the patients are post-CABG, so they have a higher risk group. In the failed cases, they even had a mortality of 7% after 1 year. So this community would show a good benefit, but they were not randomized. Let's go back to Decision in the EuroCTO trial. In Decision, the 1-year mortality is in this range. But Decision showed also, albeit in a small group, a trend towards higher mortality at 5 years. And if you put this in this diagram, then indeed there is a trend. But to find a significant difference, we would have to randomize 3,000 patients or even more to find that this will be a significant difference. So there is no proof, there is just the belief to make people live longer, but it's not necessary because for treating CTOs, according to the Constitution of the World Health Organization, to make people lead a symptom-free and unaffected life is what we physicians should do. So the question is not whom should we treat, whom should we not treat? CTO without viable myocard, CTO in a small territory without related symptoms, and of course CTO in a patient with severe comorbidity and a limited life expectancy we won't treat. Thank you.
Thank you very much. Now is the turn of Dr. Park, who will give some different views.
All right. Thank you. In terms of the last slide, actually, we are same, right? Last slide, right? However, all right, you've shown the cases examples is 2 CTOs, something like that. Well, however, I would like to focus on the single CTOs, any lesions, right? Look at that. Very young, LAD total occlusion, good collaterals from the right coronary artery, actually no symptoms. Very surprisingly, normal saline perfusion spec, actually, you know, no ischemia base, proxy total occlusions. I don't want to open this. Another female, RCA total occlusion. I want to focus on the single coronary CTO lesions. Good collaterals. Look at this. From the left side, absolutely normal. Good collaterals from the LAD, no symptoms. Look at this, normal perfusion scan, negative trigeminal exercise test, right? I want to just focus on the ischemia-based. Look at this. I don't want to open up this right coronary artery for this patient, right? And another examples. I want to just focus on the single CTO, right? 2 CTO concerns we want to talk in the later. 75 RC CTO, good collateral, excuse me, no symptoms, very small, medium size, reversible ischemia. Look at this, treadmill exercise test, 75 old men, old gentlemen, heart rate, and grow up to the almost 30, 50, 60. Anyways, as no STTAP changes, negative treadmill exercise, good exercise performance. What do you think? I don't want to open this, three examples, all, single CTO. So just you mentioned symptomatic is good. We have to do that. Survival, angioplasty. Current is any data, survival benefit, mortality benefit actually is directly related with the jeopardy myocardium. So ischemic burden, there is many issues. So, excuse me, main and 3 vessel is survival angioplasty. However, asymptomatic, small ischemic burden, negative FFR, no evidence of ischemia, so that is kind of a cosmetic angioplasty. CTO, pathophysiological concern, I think is a little bit different with 90%, 95% of stenosis. As the various ischemic ratio due to various collateral circulation, and clinically, no ruptures during the follow-up period. And the meaning is, I just mentioned about the FFR concern. All right, this is all data, you data, right? Dr. Orange data. However, look at that. Chronic total occlusions, in any cases, chronic hibernations, in sometimes combined with the stunning something, we cannot representative is open up FFR cannot representative of current status of those those patients. Anyway, look at the 3 different cases clearly gave us some insight that there are barriers ischemic ratio due to a collateral circulation. We're going to have some study for that. So improved quality of life. They are already functionally good enough in a young gentleman. 75 male patient. If you look at the activity of daily life, person pick VO2 concern, even in the normal, patients, healthy patients in daily activities, actually we're going to use less than 50% of our Vmax, capacity of our exercise. Even in the patient congestive heart failure, they use, sorry. All right, just less than 50% of our, Vmax O2 consumption in our daily activities. Survival benefit, using some data, all cause mortalities, meta-analysis, and clearly show that a favorable success, CTO, PCI, better, survival. So I would say all biased registry data. Look at this. You got this Euro CTOs, very limited randomized study clearly cannot show any survival benefit. This is our registry data. Couple of Myers unadjusted deaths, not too much difference. Deaths over QMI, failure, success, and the meaning is in the registry data, any difference is maybe related with the bias, the patient, characteristic selection is a bias, something like that. And so last year, PCI versus optimal medical treatment, sorry, some compare meta-analysis that didn't show any difference between the two. Just, Gerald showed this data, no difference segmental wall thickness by MRI study. Even in the normal LV function, no difference at all. All right, I want to, so do you have any data about improved ejection fractions after the CTO open up? In any, even in the, look at this, any, cerebral revascular surgery, CT trial for the, ischemic heart failure, the ejection fraction is 28%, 32%, something like that. Even cerebral revascularization, the ejection fraction, it changes a little bit. Even in the, stem cell therapy for the, heart failure patient, the ejection fraction improves 3%, 5%, all right? That is not big matters in terms of survival concern. So do you believe survival benefit of CTO is only a different, treatment modality? Is it different from other PCIs? Actually, just only data, courage study, 15 years follow, no survival benefit for PCI compared with the optimal medical treatment. any meta-analysis, including 7,000 patients, they didn't demonstrate, any survival benefit of PCI concern, even not, So I would say any single vessel CTO PCI, any single, stenotic region PCI cannot have any survival benefit. The reason why, compare that any large survival angioplasty is a relatively small ischemic burden. We're going to treat, even in the proximal LAD, there are barriers in the ischemic threshold. And so single LAD, PCI cannot make a survival benefit. I believe that one. All right, survival benefit of a multi-vessel disease revascularization, yes, I know that. Survival benefit, however, bypass surgery is better than the PCI. These last years, we have a lot of meta-analysis, patient-level meta-analysis, and compare with the PCI versus surgery. PCI is good, non-main and non-diabetic. Diabetic patient and multi-vessel disease, absolute bypass surgery is better. So we've discussed a lot about that. Multi-vessel with the CTO is more dangerous, I think. The reason why diseases non-CTO vessel should supply larger ischemic burdens, including the CTO territory, and multi-vessel disease with the CTO region is more at risk. Just Gerald showed this slide. But multi-vessel with the CTO is have a more mortality concern. Multi-vessel disease with the CTO lesion, actually, I want to show some case. Very tough. RCA CTO and multiple disease. Anyway, particular this case is very tough cases. However, we treated complete revascularization is multiple stent for, this is very aggressive, complete revascularization. However, another case is 3 vessel is already total CTO here and circumflex disease, right coronary disease. We're going to fix up the PCI for non-obstructive, non-CTO lesion, and LAD, just we try the medical treatment LAD CTO region. And in current practice, from our registry data, treatment for the multi-vessel disease with CTO, bypass surgery, and CTO PCI with the non-CTO PCI, that is CTO, aggressive complete revascularization, and optimal medical treatment, just leave it alone, the CTO PCI, CTO lesion, and with a non-CTO PCI. All right, I want to more fast addition CTO study, Courage randomized study for CTO. So we have CTO lesion PCI and optimal medical treatment, no CTO PCI, with a non-CTO region PCI. The meaning is we compare, to be honest, the single vessel CTO compare with the open up and medical treatment by decision CTO study. Very matched clinical finding and stable, and LAD is more common. Multi-vessel included 74% syntax score, 22, JCTO score 2.3. Primary endpoint, death, MI, stroke, any revascularization, the intention to treat, absolutely no difference. As a treated population, no difference. To be honest, this is publication data, quality of life measurement over time is no different. The big improvement, large improvement, and meaningful improvement, the clinical quality of life is a little bit different. Look at that, statistical different and 1 year. However, 3-year follow-up period disappeared. Kind of I don't know, it's a rate catch up, it's a placebo effect. And so exactly the same slide with Dr. Gerald, single vessel CTO, concern of a single vessel CTO, optimal medical treatment is mostly safe and effective. Multi-vessel disease with the CTO, non-CTO lesion PCI with the optimal medical treatment for CTO lesions would be an effective alternative for those patients. Multi-vessel disease, 2 CTO, 1 CTO, I believe surgery is better, right, in current practice concern. So I would say, all right, there is the last slide. However, where is the benefit? I would say just a symptomatic, right? All right, thank you for it.
Okay, I think there is no discussion. We have reached 6 o'clock, so I wish everybody a nice evening and back tomorrow morning. Thank you.
No discussion.